sleeve, and about 1 out of 500 for return to the operating room. And about a month ago, Mercedes had a patient up here. She showed up with tachycardic, you call me? And
she's tachycardic and her blood pressure kept dropping.
yeah, so I mean, that's the ID that has to be made. You know, that's, for me, that's the main job that the nurses do for my patients in the 24 hours post-op. So the first sign of bleeding typically is just tachycardia. If you've got a patient running a heart rate of 120, that should be what you're thinking is wrong with the patient. Right? So when I have on my orders, automatic orders, if the heart rate's over 110, I'd like you all to send a hemoglobin, give a bolus of normal saline, a liter of normal saline. We stop the toradol and enoxaparin so that they don't have any medication that would contribute to the bleeding. And then you got to notify me. Right? So that's from my perspective, that's the number one thing to watch out for. Whether it's a sleeve, a bypass, bands are really low risk. They come on the same thing. But for vision patients, theoretically, they have a higher risk of all that. I'm going to tell you, I think their bleeding risk is about the same. So, but you still need to pick that one out that comes around every once in a while and be aware of that. It's a little difficult from my perspective that the tech does the vital signs and walks around and does them all and then eventually puts it in the system. That doesn't really go with what we're talking about, you know. I mean, I think that the nurse needs to be aware, the tech needs to be aware, everybody on the team needs to be aware if there's an abnormal vital sign. They're called vital signs for a reason. I would say that's the number one priority with a post-op patient in the first 24 hours. The other thing I like to see is I like to see urine output, because that's an indicator of volume status too. So if you don't record that, I don't have an idea. So the patients today, Mr. Zio's got over a liter of urine output. It's very unlikely she's hypovolemic if she's got that much urine output. Some of the other patients have only been recorded, Ms. Beltran's only recorded at 300. So, you know, I don't know. That's a little bit of a red flag. So when I go in, I like to assess it. You can look at a patient and get a pretty good idea of what's going on just by looking at them. Okay, so the first thing I do usually when going, I talk to them, and I just get a general sense of where they are. So if they're awake and alert and bright and answering questions and they don't look sick, they don't look toxic, they don't look like they're having an issue, that's a good thing. I mean, that's pretty much going to be a very good indicator that things are going fine. If it's the opposite, there's something probably wrong. You have to be on your guard that there's something wrong. Mental status changes for sure something bad is going on. So you have to be sure about that before we assume it's, oh, she just got too much morphine or whatever. We had a patient a lot of you are familiar with, who went to recovery room after procedure. I started doing the case after that, and the nurse from the recovery room came in and told the anesthesiologist, yeah, so-and-so's, you know, really not responding very well. I think she got too much morphine. Well, that's a plausibility story, okay? It could be, but the more dangerous thing is she's bleeding enough to get hypovolemic to have a mental status change. And instead, that's what was going on with that patient. I heard that in the operating room, so I had somebody go check, but immediately after I got out, the first thing I did was go beeline straight to the recovery room, and we had to take her back to the OR for bleeding. So I would say, for sure, that's the main thing I would get across from a nursing perspective. We of course want you to monitor for other things, you know, their temperature and that kind of stuff. And I'll tell you, when it comes to sleeves, leak does not usually happen in the first 24 hours. A leak symptoms typically come on 5 to 15 days after surgery. And we always check in the operating room for a mechanical problem with leak. So we do a blue dye test with the methylene blue and look for a leak. In 2,000 plus sleeve patients, we've never seen a leak. So it's not as easy as a technical problem with a staple line or something like that. It really doesn't happen unless there's something super weird with the surgery. surgery, from my perspective, I don't continue on if there's something super weird. We have to address it right there. So assessing them for a leak is probably low yield, like really not worth it, to be honest. Of course, you check their temperature and all that stuff. Respiratory rate is probably important and it gets ignored a lot. People just put the number in. I've been to places, not this place of course, but where everyone on the floor has got a respiratory rate of 20. Okay. That's not reality. So if you see someone working to breathe, that's another sign there's a problem going on. So you should stop and go, wait a minute, this person's got nasal flaring and they want to sit up. There's something going on there that's an issue. And then the other thing is, I would say, sort of housekeeping on their pre-existing medical conditions. So obviously, if you've got a diabetic, we want to be sure that the blood sugar's not out of control, that they haven't had glycosuria and peed 3 liters out, and now they're hypovolemic because their blood sugar wasn't under control, something like that. And then, blood pressure and those kind of things. For sure, if someone's got cardiac issues, arrhythmias and stuff, they're probably not going to come up here. They're probably going to go to intermediate or the ICU. But those patients are rare. I mean, in 20 years, I've had one person have a post-op heart attack. One. Okay. It's just not a common thing. So, I mean, we need to be aware of that, but that's not a high yield situation. So, I would encourage communication on the vital signs. That's the most important thing. My patient's pretty simple. They get IV fluid at 125 an hour overnight. They need to ambulate within 4 hours of the end of the surgery, not from the time they get here, from the end of the surgery. Early mobilization is probably the key to avoiding a DVT, and all heavier patients are higher risk for DVT. So we do Bovinox, we do SCDs, those things need to be on and working, but when the patient needs to be out of bed, walking, I tell them 1 lap around the nurse's station within 4 hours of the surgery. And we've had very, very, very few problems with DVTs and PEs in our patient population because early mobilization is prioritized. Diet, no one is going to get anything beyond a low sugar, clear liquid diet for my patients if they're fresh post-op. So broth, iced tea, sugar-free popsicles okay, sugar-free jello's okay, all that stuff's fine. You don't need to push protein while they're in the immediate post-op period. Hardly anybody with a sleeve ever gets protein deficient, so it's something to work on later if there's an issue. I don't have the patients measure cups, because I don't think that's very effective. So I tell them, and we're going to go talk to Mr. Seuss, y'all come in here. I tell them I want them drinking small amounts frequently, and our target endpoint for that is a urine that's clear or really light yellow, and their dry mouth go away. If they're drinking enough to get that, whether it's half a liter, 2 liters, then they're good. Right. When they go home, I give them a card that's got bad symptoms we're watching out for with my phone number on it. So if anybody has any of those symptoms at home, they're going to call me immediately. But this is their discharge instructions should include, and I give this directly to them, but if you guys want to echo what's on this card, those are basically the things, the safety flags we're looking for patients. Medication-wise, when they go home, I try to avoid, I don't like oral medications in the first 24 hours. We give IV forms of everything while they're in the hospital. So instead of their blood pressure medicine, they'll get an allopurinol IV or they'll get a labetalol IV. Instead of their diabetes medication, they're going to get an insulin sliding scale. So I try not to give them any oral medications. Somebody called me last night for simethicone. It's really not gas pain for the most part, it's surgery pain. It's okay if it's liquid, it's not okay to big simethicone pills. I don't want that going through a fresh sleeve or a fresh black. When patients go home, I do have them crush up their medications for the first 7 days, essential ones. So in my mind, essential ones would be blood pressure medicine, usual dose, usual time. I usually have them do their thyroid, if they're taking something for that. Diabetes medication, I kind of go on what the Accuchecks have been showing here. So most of the time they'll go home on half dose of their oral diabetes medication. I don't want to give them full dose because they're on a strictly low sugar, clear liquid diet. I don't want them bottoming out at home. So I'd rather have it run a little bit high than low. So I usually go to half dose. If they're super well controlled here, sometimes I just have them stop it. So it's quite a, we play it by ear when it comes to that. I don't have too many patients with anticoagulation. If we do, usually we've gotten a consultation about bridging therapy, so they may go home on Lovenox. So that's individualized, it's not right now. All right, why don't we go over